Welcome to the Cyber Health Podcast. My name is Tiffany Pirano, and we'd like to welcome to the studio today our guest, Dr. Syed Razi, a renowned thoracic surgeon. Welcome to the podcast, Dr. Razi.
Thank you, Tiffany, and thank you, Stephen. It's a pleasure to be here.
So, the question a lot of our viewers may be asking themselves, what actually goes on in an operating room? Because, most of the time patients are asleep. By the time they get to the OR, they just won't remember anything because of all the drugs they've been given. So, what would you say is your typical day in the operating room?
So, that's an interesting question because there are the time that the surgery starts is a culmination of multiple events happening in the background, all geared to get the surgery started on time. So I'll give you my perspective, and then I'll tell you what else is going on. So if I have surgery, I know my day starts early. Typical operating room starts about 7:30. So I need to be in the hospital well before that to see the patient in the pre-op, confirm the plan, get the consent, or get all the papers signed, history, physical update, round on the patients who are admitted in the hospital so their plans don't get delayed. But while I'm doing this, there's a lot going on inside the operating room, the actual operating room where the surgery will be happening. There is a cleaning crew that is working probably through the night to make sure, get everything ready. Then there are OR techs, scrub nurses who are working, I would say, round the clock, in different teams, making sure that all the instruments are appropriately stacked. And for given nature of surgery, they are brought into the operating room, counted, logged, cataloged, everything. Any specific request for that particular surgery the surgeon may have asked for. It's almost like going on a flight. You just walk in and get to your seat, but there's a lot that is going on in the background. Then on the patient side, when patient walks in from the intake, somebody who's registering, they have already received all that information. Even days before patient actually their surgery, they get the pre-operative team, the anesthesia team. They have people who are assessing patients' risk factors, making sure that their patient is safe to go for anesthesia. So there's a lot of people who are working in the background for every patient to make sure that that their paperwork is ready. Every surgery requires authorization from the insurance, so that you can go
That's
even further back.
Thing.
Exactly. So there are a lot of crews that are working in synchrony to make sure that surgery starts on time.
Yes, we all know about start times in the OR.
Yes.
Very important.
Yes.
So Dr. Razi, now that we're taking us through the journey of being in the OR, once a patient gets into the room, what exactly happens from the stretcher to the OR bed?
So once the patient, the first thing they remember are the faces, and they all look the same, because they all have their head covered and their face covered completely. A lot of times the providers, anesthesia and the OR nurses, they're all talking in medical terms. They don't know. But what patients do remember is very little gestures, a little smile. Somebody says, hey, everything will be all right. Anesthesia telling them jokes. Think about your favorite vacation time that you will be going to once they start getting those anesthetic medications. And I think those experiences are very important for the patients, because that's all they remember. When they wake up from surgery, oftentimes they don't remember anything other than what they're seeing, a bandage and the dressing and the tapes. That's all they're going to see. And I think that's really the opportunity for the healthcare where we can shine, where we don't consider those trivial. We don't consider those subtle. They are very important for the patients because that's what they are experiencing. In my career, have gone through multiple healthcare systems, multiple hospitals. I've worked with a lot of people. And when I'm going to a new hospital and going to their operating room, a lot of people don't know me. They don't know me personally other than just my name. I don't know their background. It's funny, but I may have difficulty recognizing them outside the operating room because I'm used to seeing them with their mask and head cap on. But immediately we are geared in that moment. We all know our respective role when the patient comes in. even if there is a traveling nurse there, she knows exactly what she needs to do to provide. So the harmony of multiple groups at every level working together to provide the care for that patient, I think it's if you really just take a moment, and we do actually experience that moment in our timeout.
Right.
So when we do our timeout, that's like a 30-second break where everybody's just, okay, let's hold off what everybody's doing. Let's make sure we have the right patient. We identify the patient with their name, their medical record number. We discuss the proposed surgery. If there is a site involved, right versus left, we make sure that is correct, any special needs. And also to kind of introduce, hey, you are the new person, what's your name? So everybody know each other, everybody know their respective roles, and that's when we start. Yeah. And it's really a, it seems very mundane when you keep doing it every day over and over again. But when we think about it, it's really marvelous how we have, our healthcare system is so intertwined. And of course, that also poses opportunities where we can improve.
Right. I think it's pretty cool, honestly, that when I was working in the OR, that you don't really think about it on a daily basis, but very few people get to do what you do, work in surgery, basically change people's lives on a daily basis. I think that's pretty awesome. So my hat's off to you for being able to do that every single day. It takes a lot of power, like brain power, physical power, I don't know, everything, because you're up early, you probably go to sleep late, you have a lot of cases, you're in the office seeing patients, you're rounding, you're doing surgeries, and you have a family. So my hat's off to you for that.
Clearly, I do not do it alone. I cannot do it alone.
Yeah.
And I rely on my team, not just in the operating room, but even outside the operating room, and in our offices. And our whole crew, they are motivated. I'm a parent. We have 3 wonderful children, and our children have had medical needs, and there are times when we are on the other side, and that's when we really value even those little gestures, how much it means, and when you build those relationships on a personal level, and it's really impactful. And that's when from time to time you should reflect on your own actions as a physician, so you don't get into the routine of just delivering the same care over and over again, but you really take pride in giving individual care to many patients.
Yeah.
And making sure that their experience is as good as it can be. I'm a strong believer that there is nothing in life you can take for granted, even your healthcare system. Yeah. And there is always room for improvement. You always have to keep looking for opportunities how we can improve.
How exactly do you perform lung surgery on an inflated lung? That makes sense.
That's a good thought. And actually, it's something my patients ask very commonly, that there's no space in the chest. And that's where I would really commend the skills of our phenomenal anesthesiology team. They are great friends and very skilled people. They use a special technique called single lung ventilation. And what they do is we have special endotracheal tube designed such that during surgery, we can keep one lung inflated and working, that allows patient to breathe, and one lung deflated, so the air goes out like a balloon. And when the lung gets deflated, it creates a lot of space in your chest. And that's when I can bring in my robotic arms and a camera and all kinds of instruments, operate on what I need to do. And it's very critical during these cases that anesthesia be able to maintain that lung is staying deflated, which is unnatural. In our lifetime, it never happens. And anesthesiologists are able to do it routinely and safely, and then be able to bring it up towards the end of the case. So it's remarkable.
Is there something about the operating room that you truly enjoy, that's like your number one thing that you would say that you love about the OR?
Among many things, is the teamwork. And as surgeon, you are like the captain of your ship, and the life in the operating room revolves around the patient and the patient's need. And there are times when surgery is results in challenges and demands change in course, demands bringing in additional people, additional resources. And I think that's really when the width of the operating team gets tested. And what I have seen truly remarkable across different types of healthcare systems is if the patient is not doing well in the operating room and you need help. I have always seen many different types of surgeons, anesthesiologists just running and rushing to come to help you, help the patient, and whatever they can do.
Asking you a few questions about your background. How did you get involved with surgery? What made you choose this career?
Well, regarding my background, I'm from Pakistan. Grew up there. My family environment was always going for the best in academics, in your school grades and everything. My parents always wanted me to be a doctor, so that was a given for me. And as time grew on, my interest also increased. I knew from the beginning when I started my education in the medical school that surgery was the field for me. It just came very natural, dealing with things directly with your hands, making changes that impacts patients' lives. And with that, I continued, my education continued. And it was really when I came to United States that I got exposed to thoracic surgery in New York at St. Luke's Roosevelt, where I was a postdoc research fellow. And my mentor, who's still a very good friend and a mentor, Dr. Bora's lab, where I got exposed to really what's new, up and coming in the field of lung cancer treatment, and what role a thoracic surgeon really plays, not just for the treatment or surgery, but in the entire journey that the patient goes through when they are diagnosed with a suspicious lesion that turns out to be lung cancer. So that's really what grew my interest in. And after 20 years, all I can say is I'm proud to be a thoracic surgeon.
And you said you grew up in Pakistan, or you were just born there?
No, I grew up there.
You grew up there?
I came to U.S. when I was 24-year-old.
Oh, wow. Okay.
Yeah.
Do you think there are any similarities or dissimilarities, I guess, with the healthcare system in Pakistan versus the United States?
Well, we have a public healthcare system that is free to all for everyone. And then there are, in private sectors, there are several institutes. In general, the delivery of healthcare system, there are similarities and dissimilarities. A lot of advancements that have happened in the last few decades, they are comparable to certain standards, and a lot more needs to be done. I do see opportunities for collaboration with thoracic surgeon. We have a group actually on WhatsApp where there's more than 150 cardiothoracic surgeons, and I'm glad to be a part of it. We do collaborate very regularly and seek opportunities that would benefit both our thoracic community here and thoracic community and patient population back in Pakistan.
Oh, wow. That's amazing. Yeah. Here, do you think there are any differences between being, say, like a regular physician versus a surgeon? Is there a difference in providing a level of care, or?
Interesting question. I would think of it this way, that as a physician, you have a choice. You don't need to be a surgeon. But the same doesn't apply to a surgeon. You have to be a physician first. And that being said, if a patient comes to me, it's my duty to really look at the best for the patient. And oftentimes it involves not going through any surgical intervention, but you have to be patient's physician.
Right. It's not always surgery first. So you have to do what's right for the patient. Right?
Correct.
Mm-hmm. Do you have a favorite surgical procedure that you perform?
I would say I like all of them.
You like all of them?
I have to give my everything in every surgery that I do. I don't consider any surgery less important than the other one. For that patient, it's that one surgery that he's getting. Right. Having said that, what really inspires me is not just the surgery, but the overall care that we are able to provide to our patients. And take an example, I deal with a lot of patients with cancer, and whatever modality of treatment they are going through, if I'm part of it, where later on, once the care concludes, I can say and tell them that they are cancer-free, then whatever procedure I've done, I would be glad to be a part of it. So I can't really say I have one favorite procedure or the other.
Okay, that's great. I really like to see surgeons in the operating room when they're doing robotic surgery. I think that's really interesting, like how they use the the technology to help save lives basically. But you can get into such intricate areas with a robot that maybe you can't with your own two hands, and I just think that's really cool.
That's yes, that's correct. One of the biggest misconception with the robotic surgery is that somehow the robot is delivering the care, because it's really my hands in there. And you are absolutely right, Tiffany, that the robot, what's allowing me is to get to the areas that will be otherwise difficult to access, and in a environment which is very stable, highly magnified, and you can perform really delicate dissection. But having said that, at the end of the day, robot is a tool. I have seen masterful surgeons who are able to deliver the same kind of an operation even without the robot. So ultimately, it's the surgeon's skills, the skills of the team that really gets the patient through safely. And yes, robot is an important tool. And as I see where we are heading, there will be better equipments. Mm-hmm. There will be more refined technology. We have AI. I'm sure in future we will see more of an involvement of AI in the conduct of surgery, all surgeries, not just robotic surgery. Mm-hmm. And the idea is that we use these tools judiciously to allow us to deliver the best surgery we can for our patients. When patients are diagnosed with lung cancer, overwhelming majority of them are diagnosed when they don't have any symptoms. Mm. They don't breathe it, they don't feel it, they don't feel any difference in their breathing. It's diagnosed purely incidentally. Oh, wow. By multiple ways. They get a imaging for some other reason. They go to emergency room with a chest pain and for various reasons get CT scan, or they got into an accident that led to a CT scan, or they get lung cancer screening CT scan, whatever cause it. And that is the time to really act upon it. The radiologists read it as an incidental nodule or a mass or what have you. Or if there are previous studies, they compare it. And sometimes they see that this mass wasn't there before. Mm-hmm. So how do we really pick it up? Then the onus is on the providers who see those reports and then make appropriate referrals. But as you can see, it's a big cast. And there are times when either patient doesn't understand what nodule means or don't appropriately follow up in due course of time. And that's where the opportunity is. We have been using AI-driven platform, and there are a few of them out there. And what they do is they use those buzzwords in the radiology report and generate, so to say, a patient list for you. Oh, and wow. They categorize them into high risk, medium, low risk, and they provide those lists, thousands and thousands of lists of patients. And then you have to, or your team and the nurse navigators, we have to go through each and every one of those and see which ones really need attention. Majority of the nodules are lymph nodes enlargement or whatnot. They're non-cancerous, but you can't really tell with just imaging. So there are ways to address those. Most important is patient education and surveillance. And by doing that, our hope is using this AI as our friend, we will be able to capture all those incidental nodules in a timely fashion, and be able to reach the patient before the cancer advances.
Something about cancer screening and the nodules on scans. What exactly is a nodule for those listeners or viewers who don't know?
So nodule is a term that we use for any kind of abnormal growth in the lung parenchyma. And we call it nodule when it's up to about 3 centimeter. Beyond 3 centimeter, we call it a mass. But ultimately, all that tells by reporting that there is an abnormal growth and it is of concern. Not all nodules or masses are cancer. In fact, majority of them are not. But you can't tell by just imaging, which is why additional tests are needed to confirm whether they are benign, something that can be just washed, or is that something that needs additional workup.
Okay. Is there a particular age group or gender that is more at risk for lung cancer?
Historically speaking, you would think that smokers, they're at high risk, males, and patients above a certain age. U.S. Preventive Task Force looks at high risk category between the age of 50 to 80 with smoking history of more than 20 pack years. And that's who they recommend for lung cancer screening. But I think in the last several years, we are seeing an increasing trend of diagnosing lung cancer in patients who have never smoked or those who are younger. So it's just a matter of being cautious. We shouldn't just ignore if the risk factors are not there, but there is an abnormal appearance on the scans.
Do you think it could come from like the environment that we live in? Maybe like pollution or increase in some kind of gas? I don't know.
I'm sure there is some association, but it hasn't really panned out to our understanding just
like
yet.
Studies or about it. Or
Correct.
Anything.
We do know of certain toxins, such as asbestos. Of course, now it's not used, but asbestos takes 30 to 50 years. So since it was banned in the mid-1980s, we still have high-risk population for the next 1 to 2 decades who may still end up being or diagnosed with cancers that are related to asbestos. Lung cancer being one, the other is a mesothelioma.
All right. Oh, and just because I do have a young son and he tells me about various stories. He's in high school now. So he tells me about various stories about kids and their crazy school things. But there was one particular time where a student was caught vaping in class. So I know that vaping is a big thing now with the young kids. How do you think that affects, overall lung health? I've heard that it's like 10 times worse than smoking, like we don't know what's inside the vape, what they're putting. So what are your thoughts on vaping?
You're right. It is a type of toxin at the end of the day. It's not natural. We know of the effects of smoking after studies spanning more than 5-6 decades. We don't know much about vaping yet. We don't know the long-term effects, but we are already seeing evidence, even anecdotally, that patients who are exposed to vaping at an early stage have higher propensity to develop interstitial lung disease, which is a type of high density of scarring in your lungs that affects breathing and have long-lasting consequences. Right. So I think we need to teach our children that vaping is not a substitute for smoking and it's risk-free. It has its own set of risk factors. Some we know, some we may not know for some time to come.
Yeah. Say no to smoking, kids. Are you involved in any research in your field that's exciting or innovative that you can share with us?
I have been involved in the research from the beginning of my career. I started working in the lab with rats and mice. That was a basic bench work research. Taught me a lot about, really gave me an opportunity to take a deep dive into the cancer world and see how the lung cancer really works at a molecular level. Nowadays, we are able to provide a very personalized treatment to our lung cancer patients and various types of cancer, even esophageal cancers, depending upon their genetic makeup of their cancer. Requires us to do advanced molecular assays on multiple cancers. And I was involved in that benchwork research to some extent during my lab years before my training. Now I'm continuing my research work with large databases such as SEER and National Cancer Database. And we are able to evaluate large number of patients from multiple institutes across the country and probe different questions. Our group was recently selected as the winner at the annual Society of Thoracic Surgeons meeting in 2024, San Antonio. This was in January. And we were awarded Maxwell Chamberlain Thoracic Memorial Award based on our research work from National Cancer Database. We looked at patients with locally and regionally advanced lung cancer, but from stage 2 to stage 3, who undergo surgery, and what modality is best for their treatment, giving chemo and immunotherapy before surgery to try and shrink the tumor, so to speak, or to hold off on those systemic treatments and give them after surgery. This is the biggest question we as thoracic surgeons face in this day and age. How to best assimilate multimodality cancer treatment for a given patient. And that is the focus of my research. And I'm hopeful to continue to take part in it in the near future.
So are there any ways that our listeners or people watching that they can improve their overall respiratory or lung health?
That's a good question. I think the important thing is you have to know your health. You have to know what are the risk factors. And you must not ignore any symptoms. The symptoms could be very innocuous, such as just cough that is not improving. Go to your primary care, speak about it, follow their recommendations. If you are a smoker, speak with your family and friends, and also seek out help in terms of how best to cut down and ideally quit smoking. It's difficult. I feel for my patients, just recently, a lot of them have been smoking throughout their lives, and it affects them psychologically. And if I am part of their team and taking them through surgery and counseling them for smoking cessation, then I have to really come to their level and try to be an advocate rather than just commanding them.
Right.
So those are important. Our social support system, family support, and access to care, not just the primary or PCP, but also to any other specialists that the patient is seeing, such as pulmonologist or any rehab treatment or whatnot, that they have to really follow through on those recommendations.
Okay. So you mentioned earlier about sometimes there being an insidious onset of lung cancer, people not knowing that they have it. Is there a genetic component maybe or genetic testing that people can do to help screen?
With regards to risk factors, there are certain cancers where genetics play a huge role. I will give some examples, such as BRCA testing for breast cancers. So far, we know of certain syndromes that makes the patient susceptible to lung cancer, but for your majority of lung cancers, we haven't been able to pinpoint a genetic risk yet. But to the other point that you mentioned about patients who have lung cancer, it is important for us to understand its genetic makeup. We do molecular assays to see if those patients harbor targeted mutations that could potentially make them a better candidate to receive immunotherapy. I have now patients with lung cancer, even stage 4, who are only getting their treatment in a form of a pill. So no chemotherapy for them. And the only way we are able to offer them that treatment is by way of really taking a deep dive into the genetic makeup. We call that new generation sequencing. It's a proprietary test, and we do it routinely for all stage 2 and higher cancer patients. And only by doing that, we can offer patient a true personalized anti-cancer treatment.
And immunotherapy, for those that aren't familiar, what is that exactly?
So it's a new class of systemic treatment. Historically, cancers were treated by cytolytic drugs, commonly known as chemotherapy, which has a very cytotoxic effect on not just cancer cells, but a lot of different types of cells related to them. Immune therapy is a different class of treatment, and it's geared to basically arm your own immune system to act against cancer cells. Okay. It doesn't kill cancer cells, so to speak, directly. And by doing that, you have a better chance that when you give immunotherapy in combination with chemotherapy, you get a much better result. Okay. And in a much higher proportion of patients, we are able to see how we call it pathologic complete response, meaning that their cancer completely goes away.
Oh wow!
This is something that was sort of a rarity before immune therapy, and now it's not that uncommon that we are able to see patients even with higher stage that they have no evidence of cancer remaining.
And is it and can any cancer patient have immunotherapy, or is it restricted to certain types, or
the indications to receive immune therapy is evolving. FDA has given their approval for different types of cancers, but the best way to see for an individual patient whether they will qualify for immune therapy is to really consult with their oncology team. And the oncology team will then have to do additional tests on their cancer cells to see whether they would benefit from immune therapy. Because it's not just immune therapy, it's one type of systemic treatment. There are targeted agents, the pills that I mentioned earlier, and some of those targeted agents come in the form of a tablet or a capsule that you can take daily. Wow. And if patients harbor that type of driver mutation, then immune therapy is not the answer for them. Okay. So it really depends on the patient's cancer's genetic makeup, and that's why it's important to counsel with your medical oncologist.
Okay. Besides lung surgeries, are there any other procedures that you perform in the operating room?
As a general thoracic surgeon, I operate in the chest anything non-cardiac in nature, surgeries on the lung, esophagus, which is a part of our digestive system that connects the back of our throat to the stomach. Also the foregut part of the stomach that falls within our area of expertise, and disease pathologies related to chest wall and all the other mediastinal structures, which is basically everything between the two lungs. Airway, that's an important component of my area of expertise. Airway diseases from the neck all the way down to your central airways in the chest. And we are also involved with advanced bronchoscopic and endoscopic procedures, meaning where you put the scope inside the airway or in the esophagus, and there are diagnostic tests, even therapeutic, that we undertake and offer to our patients.
You wanted to talk a little bit more about the esophageal and foregut pathologies?
Yes. In my practice, I see a lot of patients with various problems associated with esophagus. Most common being acid reflux. A lot of patients have acid reflux for years, and yes, there are very good treatment with medicine that can help, but over time it can have complications. The most common being osteoporosis. Those medicines thin out your bone, can lead to secondary infection, or just quality of life is affected, where they are taking those medicines but can't eat certain things and whatnot. We do all the workup and see if they have any anatomic abnormality, most common being hiatal hernia. Sometimes part of your stomach goes into the chest. can get twisted, can also cause other organ systems to go along and herniate into the chest. So we operate on that, most commonly through the abdomen. Sometimes in rare instances, we even have to go into the chest to fix those types of abnormalities. Other complications that are related to long-term acid exposure, such as strictures, even cancer, can happen in patients with a very long-standing history of acid reflux. Correct. Yeah. With Barrett's esophagus or strictures, then the workup for those, and if they qualify for esophagectomy, then that is something that falls within my expertise. We do these surgeries nowadays in a minimally invasive fashion. You mentioned about robotic surgery. I use that a lot for various esophageal pathologies from within the chest or through the abdomen.
Okay, we touched briefly on mediastinal tumors earlier. For those listening or watching, can you expand on what exactly that is? Are they also kind of like a cancer that has no symptoms, or is it something that you would notice?
So mediastinum is basically part of our chest that we describe between the two lungs, basically. That contains your heart, blood vessels, airway, esophagus, and thymic gland. So the mediastinum is divided into different portions. The anterior mediastinum, which has a thymic gland. And I'm glad you mentioned about the symptoms. Yes, it is true. Most of those tumors will be silent. But sometimes there are certain tumors which can be associated with a very devastating set of symptoms, such as myasthenia gravis. And I've been involved in quite a few cases where patients who just presented with worsening weakness and their eyelids, it gets droopy. They can't keep their eyes open. And they see many doctors and then go through a neurologist who then picks it up, gets a CT scan. Turns out they have a big tumor in the mediastinum. How is that related to it? We then test for whether the thymic gland, normally in adults, it's just a piece of fat that's lingering. The thymic gland is very involved in childhood to build their immunity. But sometimes it can go haywire in young adults, even sometimes in elderly. And starts producing antibodies that affects your own muscles and neurons that supplies those muscles, and that leads to weakness. It can be life-threatening. And if we diagnose it, the best course of treatment is to control it first medically with special drugs that would block those antibodies. And once the patient's disease is stabilized, then we go ahead, operate, and remove the thymic gland completely. So yes, you're right that majority of those tumors are silent, but sometimes they are not. And that is why it's important to not ignore any symptoms and seek help. Wow.
Great information. Speaking of the neurological symptoms, I don't know if this is related at all, but I was watching the documentary on Celine Dion. Did you watch that? Has anyone watched that? No? Okay. She has stiff person syndrome.
Yes.
Yeah.
You're right.
Yeah. Is that that's a neurological thing? That's not anything to do with anything.
I'm not an expert on that for sure. But yes, he has a very high motor tone that causes a lot of stiffness throughout the body. And again, very, very disabling.
Yeah.
And God bless her.
She sang at the Olympics. It was great.
Correct.
It was amazing.
Yeah, it takes a lot of resolve, personal resolve to do that.
Yeah. All right. Taking a step back from the OR and the operating room, is there anything, we do live in South Florida, or you just moved back recently. Is there anything that you like to do for fun here on the weekends when you're not working?
My week is fairly busy with the work schedule and also kids' activities. That, of course, goes over the weekends. During the week, you have to make sure that the kids are, well-grounded and they're able to keep up with their requirements in school and whatnot. And then you have to make plans, and sometimes you have to bribe them. Hey, if you're going to finish all your tasks, then we can enjoy, and South Florida provides a lot of opportunities outdoors.
Right.
You can go to beach, the sunshine throughout the year. And I really look forward to the weekend to kind of unwind and relax with the kids.
So, Dr. Razi, you mentioned you're a part of a thoracic group. So do you really like your partners?
My partners? Can we talk offline? I'm just joking. No, my partners are they are my work family. They're not just my partners. They are in times of need. They are my mentors. In times of need, they are my friends. And as I said, I mean, they're truly the work family. Their patients are my patients, and I know that they will take care of all my patients as one of theirs. We work as a team, and whenever I have a complex case, I seek their assistance. And since we're talking about partners, I will mention a very special person, Alejandro Rafols. He's from Cuba. He was orthopedic surgeon trained in there, but he has been assisting. And I joke to my other partner, Dr. Razi, that Rafols is my real partner because he's there in all of my cases. And I remember when I started right after my fellowship, there are a lot of steps where I would feel a little bit nervous because I was doing it the first time on my own. Before, in my trainings, always an attending helping you out. And Rafols was there through all those highs and lows and all those learning steps. And I absolutely love working with him.
If a patient wanted to contact you to do any kind of like lung screening or cancer screening, how could they find you, Dr. Razi?
I think the best resource for lung screening is that they go to their primary care or pulmonologist if they have one. And if there's any abnormal concerns and they would like to seek my my help, then they can just reach out to Memorial Thoracic Surgery Office. We have offices in Hollywood and Pembroke Pines. And soon we'll be going to Boca Raton also. My office's staff is excellent. They'll be able to help them out and answer any questions they have.
Okay, awesome. Well, thank you for so much for coming on the show. We had a great time. Good talk, good information.
And again, thank you so much, Dr. Razi, for spending time with us and sharing your story and answering a lot of questions and sharing a lot of great information. We appreciate your guys' continued support. Follow, like us, share this video, let people know about the Cyber Health Podcast, and we'll see you on the next episode.